that it's seems to be a little bit easier anymore to sit at our own computer, have business on top and pajama on bottom sometimes.
Got me there.
I literally just found my suit coat and I did put it on. I was like, well, I suppose I better put that on. But it's great to see you all guys. And I know I'm very, very excited to where we can actually get together in person again. And you know what that looks like in a year, in a month, nobody knows, but just that we know that we're in this all together, that gives me some sort of relief. So
yeah.
Go ahead.
I just want to say thank you for making that decision and moving it to online. I think in light of the COVID cases and what's happening in our state, it was a great decision.
Yeah, I would agree with you, Sabine. We were all a little bit weird, you know, we really wanted to be there in person. We wanted to meet and greet all of you, but yeah, just safety first.
Yeah, thank you for that.
Yes. All right. Well, let's get started here. So we're just going to kind of go through some introductory things here to start off. Number one, just some housekeeping things. You know, we want to keep this pretty interactive. We have a pretty small group. So if you have questions, comments, and things like that, go ahead and just feel free to unmute yourself and interject, or else you can use that chat function. And so we welcome all of that. So first off, I just want to see which coalitions are represented today and who has all been in coalition calls lately with Mountain Pacific coalitions. Raise your hand. I don't know if you know how to raise your hand with your reactions too. Some of you might have that. Susan, I see Susan, Ray, Sabine. Anybody else got a thumbs up, their reactions? I see a few people are still connecting to audio. Cindy, awesome. Well, thank you. And so we definitely want to use this time to springboard for our work in our coalitions. And so by those of you who haven't been a part of our coalitions recently, we really want to use this as an interactive strategy session too, to understand like, where do we need to focus our work? And then I'm just going to briefly touch on our Powerful Partner Quality Awards. So historically, Mountain Pacific has done quality awards in the past. And so we're just going to briefly touch on that. So we do have a polling question. Mary, if you don't mind popping that polling question up for those of you who are on the call. Those of you who are in person, you can just go ahead and add it in if you want. So in your current coalition work, which goal lines with your current coalition focus? And you can choose any one of these. And so the scope of our work, you know, we have behavioral health outcomes, including opioid misuse and focus areas like decreased opioid-related adverse drug events, overdose-related deaths, implement pain and opioid best practices, as well as health access to treatment for mental health conditions. So very, you know, as I see that as goal one, I think of all the other factors that have played into going through a pandemic and everything else with our world and our nation right now. So, and then the second one, increase patient safety, which is a big emphasis on infection prevention, and also reducing rate of hospitalizations for adverse drug events in all community settings, and then reducing rate of hospitalization for C. diff. And then our third goal, and some of these have been modified a little bit. So our boss, Mountain Pacific's boss is CMS. And so really these kind of come down that pipe from CMS. So goal 3, chronic disease self-management. We have a lot of metrics to offer. So of course, with that improved management of diabetes, one of them is like achieve 55% referral to diabetes prevention programs and contribute to preventing cardiovascular events, among many, many others for that goal. And then 4, quality of care transitions, and that improve all cause hospital admissions and 30-day readmissions, reduce rate of emergency department visits and admissions by super utilizers. And then the last one, improved nursing home quality, is focused on improving that mean total quality score. Some of this language might be a little bit foreign to you, so feel free to just like, I don't know what that means. You can ask questions or just let it go right over your head. So a total quality score of 1258 or less. And the nursing home folks on there from Mountain Pacific can totally correct me if I was wrong about that. And then also reduce healthcare related infections in nursing homes, reduce ED visits and hospital readmissions. So I apologize, I sped through that, but we can definitely send more information out to you guys if you want to know more about who Mountain Pacific is, what our goals are, how we approach those goals and things like that. So we got the results. So I see a lot of people increased patient safety at 64%. And then we've got the second one at increased chronic disease self-management at 50%, followed by care transitions, and then nursing home quality. And last, we have behavioral health outcomes. So just curious, go ahead and put that into chat. Do you wish, oh, did I share those results yet? Do I need to share them, Mary?
Oh, it's done.
Okay, sorry.
You saw it, Alana. It's good.
Thank you. I wasn't sure if you guys saw it. So put in chat, I'm just curious of that behavioral health outcomes. If you aren't working on it because you don't know where to start, or if it's just not a concern or an issue, just curious. And then if you are, the number one was, I think, patient safety. What are some actual projects that you guys are working on around patient safety? So feel free to just stick that in chat. I see, yeah, don't know where to start. Yep, I would agree with that. A lot of people don't, and I would say even with some of the focus that we've had on like health equity and social determinants of health, we know it's an issue, but a lot of people come to the table and they're like, I don't even know which card to play. I don't know what we need to move forward on and how to make this actionable. So that's where we're together. And we're going to go further together. And that's what really our hope with these meetings will be. So where are the coalitions? So as I mentioned about our boss, CMS, communities, they've been identified and by CMS within each of our states and territories. And so within those communities, they've been marked and mapped. And so Alaska, we have 4 coalitions. And they have various work around diabetes, opioids, heart health, and care transitions. In Hawaii, we have 6 coalitions working around care transitions, chronic disease, emergency preparedness, vaccine hesitancy, and reducing readmissions. In Montana, we have 5 coalitions with work around care transitions, opioids, population health, including vaccine hesitancy, advanced care planning, and medication safety. In Wyoming, there's 5 coalitions and have been focused, and I know we all are kind of flexing, waxing and waning with our participation in our coalitions, and that is completely normal in the state that we're all in. So in Montana, like I was saying, or rather Wyoming, sorry, focused around care transitions, patient family engagement, vaccines, age-friendly health systems. And then our US Pacific territories, we have 3, 1 in Saipan, 1 in Guam, and 1 in American Samoa. And so most of the community coalition names are not necessarily that community name proper. So like, for instance, you know, Casper, you know, we know that that includes like a plethora of zip codes around a geographical area. And that was really determined by the amount of Medicare beneficiaries in that geographical area. So, and I'm pretty sure, and those of you from Mountain Pacific that are on, you can completely correct me. I think that that was greater than 62% of Medicare beneficiaries in the certain geographic area. So as far as who leads each of these coalitions, it's really a mix of volunteers, Mountain Pacific staff, and consultants that Mountain Pacific has contracts with to lead those coalitions. So it's a mix of various people. And of course, we all know that some of the people have had to step back because they're being pulled to do direct patient care or whatnot. So now I'm going to turn it over to Crystal and Eileen, and they're just going to give some updates on our current Wyoming coalitions.
Well, thank you, Alana. I'm based here in Casper, Wyoming, and I facilitate along with the steering committees for the central and southwest areas. And so right now our coalitions are, we're all, obviously feeling the effects of what's going on in our COVID rates and county positivity rates around the state. So really kind of looking at our systems and our barriers towards, our vaccination rates are severely lacking. We're below 40% for the state of Wyoming. So we've recruited Holly Shear, who is on the call today with the Wyoming Department of Health Immunization Unit, to help us brainstorm and help us with our strategic plan for that. We're also focusing on infection prevention, including one of our most overlooked resources, who are the caregivers. And so we've really appreciate our senior centers and our non-clinical entities for stepping up and helping do so by helping us with the reach of the seniors and the aging population, and really kind of aiding them in the infection prevention world and getting them trained up, because it's really them who we are seeking to help us with our hospital readmissions. And then most recently, we're working on a partnership with Wyoming Center on Aging, launching our very first age-friendly health systems echo in collaboration, and the introduction really of this initiative with the upcoming conference on aging happening happening virtually now, September 22nd through the 24th. So if any of you are registered for that, please give me a thumbs up. I want to know who's all going. And so, Eileen, I'll hand it over to you to visit about your coalition work that you're doing in your areas.
All right. Hello, everybody. Can you hear me?
We can.
Okay, great. Well, hi, my name is Eileen Ford, and I am the coalition lead for actually 3 coalitions in the state of Wyoming, designated as the Northeast region, which is comprised essentially of Campbell, Crook, and Weston counties. That coalition was in existence when I came on board almost 2 years ago now, and they had been primarily focused, like most of our coalitions were, on cutting down on hospital readmission rates. And so that coalition was in existence. Part of my role with Mountain Pacific is working to start 2 additional coalitions, one in the Basin region and one in the West region. The Basin region essentially is comprised of Hot Springs, Washakie, Bighorn, and Park counties, and not the complete entire counties in some of those, but the majority of the zip codes in those counties. And then the Western region is comprised primarily of Fremont, Carbon, Sublette, Lincoln, and a bit of Teton County. What we found has been a real challenge is starting brand new projects and new coalitions, not surprisingly, in this area of COVID, in this era of COVID. But we have had some good participation from all of these areas. We found that at this point in time, it made the most sense to combine all of them together into what we are calling the Wyoming Care Quality Coalition. So currently we meet as one entity. We have a Google group, and that is how we communicate. And so we meet the 3rd Wednesday of every month at noon. We haven't really started any new initiatives, but what our meetings have been comprised of is a lot of information sharing, bringing resources to the table. We've started doing, our last several meetings were really around a lot of talking about age-friendly health systems. And so we're kind of proceeding with some of that, trying to gauge the interest in that. And we are anxious now moving forward that we are going to have some data points, and we'll have some presentation about that or some information about that later in our day-to-day. But so for our purposes now, we've combined our three coalitions, and again meet on that 3rd Wednesday of the month, and would encourage anybody who would like to join us for those meetings, and we'll drop that in the chat here in a little bit, a link to those meetings. But everybody is welcome, because I think that even though we've got some pretty colors here and some really kind of stark looking boundaries, we're all in this together. And so we just really encourage people to work collaboratively across all designations, all zip codes, if there are projects of interest. And hopefully that's what we'll find out through today's meeting, is what we need to be working on. So Thank you.
Thank you, Eileen. Yes. And again, it's really just as Eileen said, as we look at all these pretty colors on this map, when we work together, we all benefit. And so one of those examples I want to just lead into, this was a project that by one of the coalitions that we've helped. They saw an identified need to create a medication management guide for a patient-facing tool. So not something that we would be doing for the providers, but this is something to give to patients and their families to understand how to be safe with their medications. And so we helped, proof that, do the white glove part, distribute it, promote it, market it, put it on our website. And so this, even though this was made in one state, we actually use this can be really used anywhere. It can be used anywhere in the states that Mount Pacific supports, or it could be used in Ohio or Florida or wherever. So really that's really our goal with Mount Pacific, is that we're here to support what you feel is needed for our communities. And so like I mentioned before with our Powerful Partners Quality Awards, historically, like I had mentioned, that we had awarded these quality awards, and typically we've our coalitions, I think those of you who are maybe veterans in our coalitions from Mount Pacific, that really a lot of them have been focused around care transitions, right? So now that our coalitions really, that kind of the sky's the limit within those goals that we went through, that we have a lot more community-based organizations in our coalitions. And so we didn't want to exclude those types of entities from being recognized as being a huge part of the improvement and the great work that's being done to improve our community outcomes. So internally, we are going through that process and identifying how we can be more inclusive of that. So we are planning on rolling these out more towards the holiday season. So just want to let you guys know. And if you do have more questions on that or anything, please reach out to myself or any of your Mountain Pacific staff. We're happy to answer those questions for you. All right. Well, now we're just going to move into I just want to do a really brief education awareness of what the 4 M's, we talk about age-friendly health systems and the 4 M's. And so I think maybe some of you have been a part of these calls before. As the echoes that, as Crystal had mentioned, Mark Marabella and I, my colleague in Hawaii, we presented for one of those. And we've done a lot of education and awareness around age-friendly health systems throughout our coalition. So we wanted to give a little plug for that. So I'm just going to spend a few minutes, not a ton of time, and then we'll move into our data dashboard. So with age-friendly health systems, what is age-friendly health systems? So in 2017, the John A. Hartford Foundation and IHI, Institute for Healthcare Improvement, and in a partnership with the American Hospital Association and the Catholic Health Association in the United States. So we got 3 big national entities launched the Age-Friendly Health Systems Initiative. So it wasn't just a, throw something at the wall and see if it sticks type initiative. It was very collaborative and intentional. And they set bold aims that 20% of US hospitals and health systems would be age-friendly by December of 2020. So continuing on, that has now moved into a further date because they continue to that work. And so really the 4 M's framework that emerged from the health system initiative is both evidence-based, and you're able to put that into practice reliably into each of your settings. And so to just briefly go through what matters is know and align care with each older adult specific health outcome goals and care preferences, including age-friendly, or excuse me, rather, end-of-life care and across settings of care. And then medication, that's if medication is necessary, using age-friendly medication that doesn't interfere with what matters to that older adult, mentation or mobility across settings of care. So if what matters is they want to be able to go to church every Sunday, but they're on a water pill and they have to use the restroom every 30 minutes during that time frame, then it kind of inhibits them from being able to attend church every Sunday. So knowing that as providers, how can we adjust our care plan to accommodate what matters to that older adult? And then mentation, so prevention, identify and treat and manage dementia, depression, delirium across care settings. And then mobility, ensure that older adults move safely every day in order to maintain function and do what matters so that they can get to church if they want to. And then reliable implementation of the 4Ms. It's not supported by board and executive commitment from your organizations. And anything that we do, I think that we can all speak to this, is that we do need our leadership support in order to have those resources allocated to be able to move forward. And so factors that impact the care of older adults. And so really, according to the American Hospital Association and Health Research and Educational Trust, HRET, there are more than 46 million Americans aged 65 and older, and that number is projected to double to more than 98 million by 2060. So among Americans 65 and older, 80% have one chronic disease and 77% have at least two. So just think about that for a minute. How do we manage chronic disease, and what does chronic disease impact? And so because of so many adults live well past the age of 80, nearly 75% of them will require some type of long-term care, and about 40% will require care in a skilled nursing facility. And so we think about the impact of what right now, even as our COVID is impacting just our populations and our workforce, think about that in 5 years, think about that in 20 years, what that looks like for a skilled nursing facility. So if many people are requiring these services for a number of years, the cost, whether for patients and families or entire health system, it's going to be pretty significant. So if we're not focused on the oldest and sickest people, right now our eye is off the ball. And the complex health needs of older adults make that medical care more challenging and complicated. And those challenges, as I think many of us are very aware of, transitions between care settings, side effects and adverse drug interactions, lack of care planning, incorporating those values and goals of the patient and families and cultures, poor coordination between multiple care providers, thinking about using 5 different pharmacies because not one pharmacy carries all of their medications, communication barriers with language, hearing, communication style, thinking like health literacy standards, changing care preferences that favor staying at home, also considers social and emotional experience of the aging, especially right now, how social distancing and social isolation is impacting our older adults. And so when not all of them have these issues, they also can experience, change in societal role and self-identity. So a little bit of depression, isolation and loneliness, decreased mobility, loss of independence, changing resources, including food and financial insecurities. So all these factors, they really do call for a designed care delivery system that really needs to be responsive to older adults' personal preferences and those needs. And so the amount of evidence-based programs to help our older adults, our older population, there's many, but not very utilized. Why? So if you're already using the recipe that helps augment the work you are already doing in your organizations for improvement of care, then you know how you're understanding your current state, collecting and analyzing your data, design and adapting care that is consistent with what you want to do and what your population is asking you to do, and consistent with what how you study and sustain that care, then you probably, if you don't follow those, then you probably haven't thought about what it takes to be able to be a part of this process. And so as I listed some of those recipe items, what care models are appropriate. So using age-friendly health systems, it helps to design that appropriate, beneficial type of process to help put those types of things into play. And so with the 4Ms, there's numerous templates, tools, resources. They're readily available, they're free to use, and very supported all across the board. So as I mentioned earlier, the 4 essential elements of an age-friendly health system, which is known as the 4Ms. So when you hear the 4Ms, that is what it's referring to. So what matters, again, for instance, educating care providers on appropriate, comfortable conversations with patients who have a serious illness, addressing patients' concerns and goals, involving an interdisciplinary team to meet and discuss complicated cases, and implement new ideas generated by these discussions. And so just some of those things that I mentioned, think about all the different facets of your healthcare system that you need to be able to pull in those conversations. Care coordinators, the nursing home care managers, all these different people, and you think about the communication breakdown, then you pull in all of those other factors, societal things that are inhibiting us right now, lockdown and things like that. So it's getting more and more complex and difficult. And so moving on to medication, an example is redesigning medication reconciliation processes. For mentation, it's doing things like reaching out to inpatient providers and help ensure delirium notification results are communicated and understood. Also studying the impact of dementia and illness presentation. I was just on a UW ECHO's call, and they were talking through this. Very good ECHO, I might say. Developing primary care model for fall risk management and increasing frequency of one-to-one ambulation with patients. And again, this is a framework. It's not a program to guide the care. And it's just incorporating to what you're already doing. It's not another layer of adding more onto our plates. It's a set of evidence-based tools and resources that is there for your use and for free. Notice I keep saying for free because you don't hear that very often anymore. So again, kind of talk about the black and white part of it. So the measures, so we'll be able to stratify by age, race, and ethnicity. And we think of our health equity standards right now, how we're all kind of struggling to figure out how do we capture that? How do we know how well we are doing in terms of addressing health inequities? So IHI has tools, again, to help define outcome and process measures with operation definitions and example numerator and denominators, free of use. So without a way to measure and understand how you capture those measures, your work tends to be a little scattered and can lead to frustration and exhaustion for your team. Sometimes you kind of feel like you're chasing your tail. But with help from us at Mountain Pacific and all of us together, we're in this together, we can help define, set goals along with how to measure those goals. And so some of those basic outcome measures you see here, like 30-day all-cause readmission rate, average length of stay, using your CAPS or HCAP scores to know population response for your quality of care. And then some more advanced outcome measures are collecting of older adults with diagnosis of delirium. And then you can also use this to stratify your data by race, ethnicity, gender, disability status to help address health inequities. And so I just also want to define that definition of health inequity, and that's according to IHI, is differences in health outcomes between groups within a population that are systematic, avoidable, and unjust. All right, so now I'm going to turn it over to Ray Tupling, our analyst at Mountain Pacific.
Yes, hello everyone. And yes, I will share my screen and we'll take a look at some data dashboards that we've been developing. Okay, so you should be able to see my screen now. I'll move everyone's face. So first off, my name is Ray Tupling. I joined the Mountain Pacific Analytics Department back in April. And I was really excited about this conference because I was finally going to get a chance to meet my coworkers. So I'm a little bit sad, but at the same time, I totally agree with the decision to attend virtually. And that being said, I hope to meet any and all of you at some point. I am based out of Laramie, so I'm in a relevant state at least. With that, I'll quit explaining myself and dive into some actual data. So when I joined, there was a big push to get some more data out to our community coalitions. And I say that very generally. There had been a little bit of a lack of providing data to them. And it's not necessarily through lack of trying or lack of interest. It was just a lack of manpower, so to speak. So we've been able to expand the analytics department. We've got a great member named Dominic Fitzsimmons, who has a lot of experience building dashboards like this. And he's the brains behind this. I just get to stand here and talk about it. So with that, we use software called Power BI. It's a Microsoft Office setup, and it's really designed to take complex data and make it interactive. A lot of the data we're going to be going over today comes from the databases maintained by CMS. And at last count, those databases were approaching 200 billion rows of data. I mean, it's gone far beyond accessible to a lay user. And, you know, that's why Mountain Pacific has people like myself, Joe Donahoe, Dominic, where we've got programming abilities to go ahead and get that data. But really the value of these data dashboards is it gives you access to those huge databases in a usable manner. You know, you can boil it down to the community coalition level. You can look at it at state level, zip code, however you want to cut it up. So, you know, really it's a bridge between the sophisticated data storage and the actual people who are going to have some actionable insight and be able to go out in those communities and make a difference. You know, for me, I'm really just the guy with the measuring stick. I help tell Mountain Pacific whether or not these community coalitions have improved or not improved. But you guys out there are really the ones with the boots on the ground making a difference. So with that, these data dashboards are really designed for you, the end users. And diving right in, everyone knows this is just a map of Montana and Wyoming. Let's zoom in on Wyoming. And so here we're looking at actual COVID-19 immunization rates. It's very relevant given the times that we live in. So as you can see, there's a gradient of red here. Counties, and this is at the county level, counties with relatively high immunization rates have a darker color red. Counties with relatively low immunization rates are a little bit lighter color. So you can see Teton County is approximately 74%. And I apologize, this probably looks extremely small on your screen, but you know, one of the nice things is we can actually click on any county, it'll highlight it, and you'll get to see the actual vaccination rates that are complete. So how many adults have received both doses of, say, Pfizer, Moderna, or one of Johnson & Johnson. And also down here, you see how many adults have received at least one dose. And so hopefully, you know, either account managers, community coalition members can interact with this and say, hey, my county is, you know, my county's doing good, my county's not doing good. But, you know, hey, maybe I know somebody in Fremont County. I can ask them, hey, what are you doing in that county to, you know, improve that vaccination rate? Or what is it about your beneficiaries in that community that make them more inclined to get that vaccination? So yeah, we hope it's going to be useful. We're in the process of rolling it out to account managers currently. But you know, at the end of the day, it is healthcare data, and we have to be very cognizant of PII, PHI, and especially for the community coalitions here in, you know, Wyoming, Alaska, Montana, Hawaii, and Pacific Islands. We've got very small populations. So one thing that we've done with these community dashboards is we've done our best to, first of all, get rid of any beneficiary specific information. You know, we aggregate this in the background. We also take a look at low numbers. You know, counties like Sublette County, I think the population of the entire county is about 12,000 people. You narrow that down to Medicare beneficiaries, that's approximately 15% of 12,000. You know, you're starting to get into some pretty minute populations. So you may not necessarily be able to post like, hey, there are, you know, X number of people in Sublette County with a pneumococcal vaccination. It's definitely on that borderline of shareable versus non-shareable. But with that, you know, this you know, it's really designed to help out the community coalitions. You know, we can look at data at the county level, and let's tab over to some of our pneumococcal immunization rates. And this will load up here. There it is. And this is, I will say this too, this is just it's an example data set. So take this with a large grain of salt. These are not the actual numbers, but it's in the ballpark of what a pneumococcal vaccination rate would be for a given county. So again, you can click on a county that you're interested in. You can also click through time. Up here in the top right, we've got a year indicator. So we've got data going back to 2018, all the way through what's available in 2021. And you know, as the year goes on, they update those databases, CMS does, and we can get a relatively consistent flow. We're updating these data dashboards on about a monthly basis right now. We're hoping to have as close to live as possible. So that would In a perfect world, you get to see things as they are, but given the nature of data, having to clean it, prep it, and query it from those huge databases, it does take some time. But we do our best to keep it current and relevant. But yeah, we've got data from COVID-19, pneumococcal. We've also got influenza immunization rates, and they all have the same, typical filters where you can subset down to a given community or county. And so we've got all of our Wyoming communities here. We can select these select. So if an account manager wants to focus in and share a particular subset of geography or what have you, they can really do a nice fine-grained comparison of data. So yeah, that's our immunization data dashboard. And I'll just quickly share another one. This dashboard that you'll be seeing here is a little bit finer grain. It looks at data at the zip code level. So obviously there are multiple zip codes within a county. So these maps do get quite busy in my opinion, but it really lets you look at data at a very fine level. Within your community coalition, how are zip codes performing? Do you need to target your actions in a specific zip code, or learn lessons from where things are going really well? So let's go ahead, and you'll see on the top right here, you can actually subset by geography. I've got Alaska selected. Let's go down here and select Wyoming. And given the nature of sharing screen, it's a little bit laggy, but so you can see all the zip codes that are associated with a particular community coalition. Of course, down here we don't have any coalitions, but if we zoom in to the greater Casper area, and you can look at particular zip codes, and this is looking at admissions and readmissions data. So in these particular zip codes, what are our admission rates and readmission rates? You can toggle between the two up here. And then further to that, we've got some breakdowns of our beneficiary population in these zip codes. You can look at race and ethnicity, and then just discharge status, like where are these beneficiaries going after they exit the hospital, a gender breakdown, and the top, I believe we're looking at the top 15 conditions here. What's affecting our beneficiaries in these particular zip codes. And that, I think, can really give you some insight as to what does your beneficiary community really need. And so really it's just getting some of this data out there, encouraging our account managers to share this data with their community coalition when appropriate, of course. And so, sorry, I'm just looking at the chat. If you guys have any particular questions, feel free to put them in chat, or if you can't hear me, please let me know. But yeah, this, like I said, these data dashboards really allow us to give the community coalitions access to that sophisticated data. And, this is definitely a work in progress. We are wide open for feedback on these. If you have thoughts after this presentation or, next week, feel free to email us, reach out. This really is intended to be for our community coalitions. We want it to be as useful as possible. So, it might hurt my feelings, but I'll get over it. Give me any and all feedback you want. So yeah, with that, I'll hand it back over. If you have any questions now, any questions later, feel free. But thank you.
Awesome. Thank you, Ray. So we did get a question regarding can we get onto this site?
Yes, excellent question. Yes, in a perfect world, we would just be able to open this up to anybody. Again, given the nature of PII, PHI, etc. We are only going to be allowing account managers to be looking at these currently. We're still ironing out a lot of the accessibility issues. Hopefully in the future, it will open up to a larger group of people, but right now just account managers.
Yeah, and of course, during our community coalition meetings, so we have been sharing It's essentially a PDF report of what Ray and the analytic team have been doing to help us so we understand. And I did put that in chat. So, you know, when we think about how to drill down, when we try and figure out, you know, what is the cause? What is the root cause of why we're having readmissions? Like, what would make sense to you guys to include in that so we can understand what we're dealing with, and so that our interventions and our strategies make sense to how to address that challenge or need. So you don't have to personally identifiable information, PII. Are you just asking about that, Deb?
I just wasn't sure everyone on the call knew what it meant, so I thought I would throw the definitions in there.
Thank you.
Yes,
Yeah.
thank you. Commissioner. You know, I'll admit I don't have a background in healthcare. I'll actually admit that. But
Yeah.
that's what I did.
So if you guys all think of something while we're moving along with our summit today, please just go ahead and use the chat box or just raise your hand. Oh, right. I have to pull back. You guys can see my screen again? Okay. All right. So now we're going to move into the town hall discussion and talking about what matters in your communities. And so we have, thankfully, we have 4 volunteers who have decided to come on and help us be our panelists during this time. And so we have Joanne Farnsworth, Sabine Schneck, James Whips, and Stacy Hillsticker. So I will have Crystal and Eileen introduce and just essentially introduce them, and then I'll hand it back. Then they'll hand it back to me. So Eileen.
Real quick,
All right, I'm
Monica?
on. All right,
go.
so
Oh, wait, was there someone trying to ask something?
it's Crystal. Can you hear me?
Yep.
Okay, I just wanted Cindy's comment. I did, Ray, send off those PDFs about the dashboards this morning to the Sweetwater folks, but she says she doesn't see the readmission rates on it. Are those included, or?
Are those the
Where did-
PDFs we created several weeks ago? Or are these more recent that Dominic is saying?
Oh, I see, because that was just the immunization numbers, correct?
Yep.
Yes.
Okay, so do I use the other readmission or the PDF that Dominic sent out? Is that what I send her?
Yeah, whatever you've been sent most
Okay.
recently, I would recommend. You know, early on in this process, we did send out some PDF reports that were, you know, precursors to these data dashboards. You know, it's a lot of the same data and same measures that you'll see in these dashboards. But we're on the cusp of having these dashboards live and being able to interact with them. At least account managers can interact with them.
Okay,
that
so Cindy,
helps.
yeah, I'll get you the correct info then. Thank you for clarifying that.
Perfect. Yeah. And then just to give an example, when I asked that question, so I'm just kind of scrolling through to see if anybody had any suggestions as to what would help with the data dashboards. Casper Coalition requested persons living with disabilities. Is that, you mean to like stratify the data?
I think so. I remember Holly was asking Dominic. Holly, are you on? Are you still on, Holly?
I am, yes.
Okay. Can you clarify what you were asking during the coalition meeting? I don't have my notes in front of me, but I know that disabilities came to be part of the conversation.
Yeah, absolutely. So we are just working on increasing data quality here. So race, ethnicity data. And in addition, we are very interested in coverage rates for people with disabilities. So if you can get information on that, that's great. As we look at kind of those determinants of health and health equity, it's really important to make sure we are covering our populations as best we can.
No, that's an excellent point, and actually very relevant to some of the work I've been doing over the last few weeks. You know, in August 2020, I believe CMS made some changes to their database where they now have that information, disability status for each beneficiary. So we are able to include the, is this person eligible due to disability? Are they disabled, or are they just simply 65 and older? So we are starting to roll that information up into our data. Like I said, it's relatively early in the process. I believe it was in late June that we actually found out that that information was available. And like I said, we're starting to propagate it through our data outputs. So, but thank you for that. That is certainly something that's on the horizon for us.
Yeah. Cool. Perfect. Yeah, thank you. And just another example, I work with the Bozeman Coalition in Montana, and one of the coalition leads, Dr. Catherine Borganich, she is helping to understand and like to improve capturing and understanding how well we are doing with addressing advanced care planning. And so that was one of the requests that she had. And so she's been working with our analysts as well to try and capture those HCPCS codes for advanced care planning. And so even though some of that stuff is like how Ray said, there's so much, and then they have to kind of like clean it up and scrub it and things like that. But really it's just hearing from you guys, like what makes sense to understand what are the appropriate beneficial interventions that we can do to help improve the health outcomes. That's really our bottom line. And we will do what we can to help with that. So with that, anybody have any other questions for Ray for data? Yeah, advanced care planning, yeah.
Yeah, you got somebody excited, Alana. You got Cindy excited.
Good. Yeah, it was a little unnerving to see the results. I'll just say that, but just know that there's a lot of work to be done with that. So more to come. So with that, I'm going to turn it over to Eileen. And Eileen, if you want to introduce Joanne and Sabine.
I would be happy to. Thank you. So I actually have physically with me here today, which is pretty exciting, Joanne Farnsworth. She is an RN, and she is currently serving as the Director of Quality and Compliance at Western County Health Services in Newcastle. And so that includes the hospital, the nursing home, and home health in that region. In her background, she has worked as an RN in hospitals. She served as a DON in long-term care for 15 years and has been in quality and compliance for 5 years. And I have really appreciated her help through our coalitions. I can tell that she's one of those people that has that can't say no disease, as witnessed by the fact that she is staying after the Wyoming Hospital Association meetings today and has agreed to be part of our panel. So thank you, Joanne, for that. I also want to introduce you to Sabina Shank. She is the Senior Project Coordinator for the University of Wyoming Center on Aging Geriatric Workforce Enhancement Program. She coordinates the Wyoming Dementia Together Caregiver Network, a program that provides support to caregivers of loved ones with dementia. She also collaborates with several geriatric workforce enhancement partners across the state to provide training in age-appropriate care and implementation of the 4 M's. She is also a valuable member of the Mountain Pacific's Patient and Family Advisor Committee. And so that's kind of one of the hats that she's going to wear on our panel for us today. She began her career 30 years ago in a primary care setting with a focus on chronic disease prevention and behavioral health management. She obtained her master's in counseling at California State University, East Bay, and she moved to Wyoming to pursue her passion to work with rural medical centers and community agencies to deliver exceptional care to Wyoming's aging population.
All right, and I'll take it from here, Eileen. I'll introduce James Whips, who serves as the Natrona County Coroner and certified with the American Board of Medico-Legal Death Investigators. Mr. Whips has been in the medical legal world for 22 years and can provide unique insight into how insufficient and poorly controlled pain and disease management can lead to premature death. And lastly, we have Stacy Filesticker, who is a registered nurse who holds a bachelor's degree in gerontology with over 20 years of healthcare experience. Other related work experience includes med-surg, infectious disease, IV team, and cardiac critical care. Ms. Filesticker is here today representing Banner Health and Wyoming Medical Center in her role as the heart failure coordinator. So again, thank you to our panelists who have put time and effort in today's summit and sharing their observation and expertise with us today. Back to you, Alana.
Awesome. Yes, thank you so much, the four of you. We're really, really happy to have you on. One of the other things, thank you, Mary Argonis, for reminding me about that. We actually do have a questionnaire that we would love for you as participants today. They're not the same as the panel questions, but they are just helping us again to get insight from what you feel are challenges. And so she is going to just put that link in chat right there, so you can go ahead and fill that out as now, later, whenever, and then we would love to get that back for feedback and input. So thank you. All right, so now we're going to start our discussions. And so we have 5 different focus areas to discuss, and we want to give each of these panelists time to respond to the questions that we have prepared for them. So I'm going to ask each of the panelists to respond to each of the questions, and we're going to allow 1 to 2 minutes per question because we do have quite a few questions and we have about an hour to go through all this. And so we want to spend about 10 to 12 minutes per topic. So if we do have more to discuss on these topics, we will definitely be putting these on our parking lot and then pick back up on these conversations during our next Wyoming Care Quality Coalition call, which is next Wednesday. And Eileen has already shared that link for us to join. So if you're able to and you have time, we would love to have you on those calls just to help pick up that conversation and continue on with our work here. And so also my colleagues are going to be helping to keep track of these challenges, the concerns, thoughts on solutions during this time as well. And so at the end, we've dedicated some time to go through some action items and find challenges and identify ways that we can find solutions to improve those challenges. So, all right, let's get going. So, okay, starting with Joanne, in 1 to 2 minutes, what do you feel are the 3 most effective ways? Then we will move to Sabine, and then we will move to Jim, and last Stacy. So Joanne, what do you feel are the 3 most effective ways?
I forgot to take myself off mute. Sorry about that.
No worries.
In Newcastle, we've actually been working on this with our medical staff. I think a key is getting your medical staff involved, not only your emergency room and urgent care providers, but also your primary care, educating them and then monitoring and kind of helping each other learn about the most effective ways to not only educate our patients, but to really think before we write that prescription and consider other options and just do a more thorough. It used to be, I think it was just commonplace. If you had pain, you wrote a script for a controlled substance of some sort. And we've worked very hard to reduce that, especially in our ER. So in our ER, we do not treat chronic pain. With what we do is certainly assist with appointments with a primary provider, a pain provider, and try to go that route with patients. And that has been effective in bringing our numbers down. And certainly I think our emergency room readmits at the same time. So we also considered how do we bring our community on board with education and awareness for our community to not only identify issues with a loved one, but what to do if they do. So working with different clergy in our community, different organizations, and then educating all of our staff, everybody on our team as to what we're doing as well and keeping them in the loop. So those are the things that we've been working on in Newcastle.
Great, thank you for that. All right, now we're going to move on to Sabina.
Yeah, so what I believe the three most effective ways are education about benefit and risk ratio when prescribing opioids, and education of patients and definitely providers as well, because I think, as you were stating earlier, that the natural thing is to fix it, to write a prescription. We know that opioids in the long term do not work, and then people actually may experience increased pain. I think creating care teams are also an important aspect, so people can work together, and incorporating into your care teams alternative ways of pain management. And that can be mind-body wellness, that can be occupational therapy, but really looking at pain as a complex chronic condition that needs to be managed by a number of providers and not by just one prescription. And then I believe that a lot of providers and care teams do not have the education around alternative pain management approaches. There's nutrition, there's exercise, there is stress management, lifestyle behaviors that can really greatly aid in decreasing pain, as we know from research. And so that leads me then to really looking at a third third approach is really preventing chronic pain, and that can be done earlier on. I think we're missing the boat a lot of times by not talking to our patients about a healthy lifestyle, which fixes a lot of things and manages a lot of chronic conditions, including pain, is by practicing good self-care and taking care of your body. And that's really where, as a patient, I would like to see focus on educating our patients of what can I do to not have a chronic condition in an older age.
Very good points, Sabina. Thank you. Now, Jim.
Yeah, first I'd like to make a point that I'm really not in this the same way that the rest of you are in direct patient care, but I do see the aftermath of a lot of this. And when we talk about opioid abuse, and of course probably everybody knows, I mean, Wyoming sits above the national average in opioid prescription. Right now, basically, according to the stats, more than half of our population is on an opiate of one sort or another. I feel that the best way to try and combat this, and it's going back to the last speaker here, is integration of services and trying to bring a total approach to pain management, whether that's through specific pain management clinics, more of them, providing access and information with all the effective modalities, including that physical therapy and acupuncture and you name it, along with maybe the medications. I guess marketing might be another one, where I see some of the biggest issues with like the opioid abuse. It obviously is either from people coming from the other side of tracks or people that have been prescribed opioids on the spur of the moment, whether it's out of an ER or whatever, and have that instant addiction to it, and then go into opioid seeking type stuff with revisits to the ERs and that kind of stuff, trying to get the opioids. Well, I don't know if there's any other questions you might have of me on kind of the end of life system that goes along with this opioid, that we certainly are happy to answer those.
Well, that's very good perspective, Jim. Thank you. And Stacy.
Hello, turn my video on. I do have to say I'm at home with my children, so if they jump into the screen, I apologize. I've been isolating or quarantining for COVID for the last 13 or 12 days. So I feel like everyone has made very good, valid points. And I believe, my perspective is probably for more of a direct patient care provider. I'm relatively new within the last year to my current role, but I have been a nurse, for 10 years, taking care of patients with acute and chronic pain. I do feel like three of the most important things from like a direct provider is making sure communication among patients and our residents or whatever your population is, and making sure that they understand what the pain is, how it should be managed, communicating what they expect, bringing awareness to that pain and what, expectations with that and what their pain could be and what they expect. And, having a big hip replacement surgery versus having, cabbage surgery are kind of completely two different types of pain. So understanding what they can expect after surgery. And that I guess that's my third one, would be expectations of how to manage those pains and what they could do. And then go along with that second question, definitely using alternative medicines or alternative ways to managing pain. And managing pain. So that way it is acceptable, and especially in the acute setting, so it doesn't turn into a long chronic setting where it's much more difficult to manage those patients, especially since they've been used to getting opiates, and now a lot of providers are no longer wanting to provide those for patients.
So I think we'll just move right into Stacy, if you want to continue going on with the supportive use of alternative pain management strategies. How can we help healthcare providers be more supportive of that?
I do believe probably education. I know as a nurse myself, we really weren't taught other alternative ways of pain management. I know in the hospital, we do now provide like essential oils that we can provide to patients to help with smells. I never really was taught how to do like medical guided directive visual therapy, other types of ways where we can help our patients that would be beneficial. So I definitely believe education for people to help provide those supportive measures is probably one of the biggest keys for those patients to help them.
Okay.
Great, thank you. Jim, how do you feel that we can be more supportive for healthcare providers for alternative pain management strategies?
Again, it's probably the education is a big one, but also maybe teeing off places that are really doing it right, and looking at some of their programs. And a good example of this, even though someone may disagree with me, would be the VA. They have a very detailed, all-inclusive program when it comes to pain management. I know that because I'm in it, to include things such as what they call battlefield acupuncture and yoga, and you name it, just across the board. And they're very, very interactive with the veterans on participating in these programs and literally having these pain management clinics and things like that people get into.
Great. Yeah, I think that too is just the innovative ways, and just other providers are using alternative pain management strategies, and honestly just spreading those kind of things. And a lot of people, when I asked about behavioral health, like how do you, and they're like, well, I don't know where to start. So very good point, Jim. How about Sabina? How do you feel healthcare providers can be more supportive of using alternative pain management strategies?
So I think what we need to do for our providers is really give them tools in their toolkit to talk to patients about that. Because I think a lot of times that's the biggest barrier, is how do I approach alternative pain medications when our patients are what I want to call quote unquote resistant. I hate to use the word, but just for intents purposes right now is, and I think motivational interviewing skills really come in as very important part to create a collaboration between our patients and our providers. I also understand that most providers are not necessarily trained in that. We want to identify what matters to the patient and motivate them to really be very engaged in their pain management. other than getting prescriptions. And then really providing patient-centered care with a multiple or interdisciplinary team for treatment, as I mentioned before. And that needs to be available, but the providers need to know about that. There's a lot of opportunity, I think, that we have doing these kind of via an echo type of environment where we bring different disciplines on board when it comes to managing pain. And again, I've been involved through Kaiser Permanente. We've done group visits with patients who really did not want to continue using opioids for pain management, and help them in a supportive environment, seeking out alternative pain management methods.
Great, thank you. Very good perspectives. I appreciate that. Joanne.
Hi, I think one thing we need to maybe help get providers find the time to not only learn more about the alternatives, but also to sit with their patients and talk to them about alternatives. Because I think the pattern for so long, especially in our town, our physicians have been there a long time, and you take that minute to what pharmacy should I call? And now we're going to sit down and talk about different options. And I think when you're in a primary care setting, you have so much time, and then your next patient is waiting and your next patient is waiting. So I think we need to enable them more time to accomplish this.
Great. Well, four of you definitely have very good insights so far. And so the last question, we're just going to quickly go through this one for the sake of time. What are your suggestions to improve the access to and awareness of medication-assisted treatment programs, or MAT programs, around your community? And we'll start with you again, Joanne.
Okay, well, for us, this is a huge struggle because we're very small, and we have a limited number of providers, a very limited number of providers. We do utilize some telehealth when it's available. Our struggles with telehealth have been a different provider every time you schedule an appointment, or a patient sees a different person or a different provider every time. They don't like that, and they don't come back for those telehealth appointments. So we have struggled with that in the past, trying to implement telehealth. We continue to work with that because that's our only option for kind of getting access to those treatments, because they don't exist in Weston County.
Great. Sabina.
Yeah, I agree with you. Access is a huge factor, I think, in treatment. And then I believe the awareness and also shame associated with medication-assisted treatment programs. I think so. Really, a huge educational campaign. What does that look like? Creating awareness, and also normalizing medication-assisted treatment.
Yeah, I'm hearing a lot of people, that's kind of a common thing, is normalize that and destigmatize that. Yeah. How about Jim?
Well, I'm on with everybody else. First of all, there's got to be these programs in place in the community, and if they are in place, do the people know about it? Are our primary care providers and everything pushing this, whether it's through marketing or whether it's however we're doing it? Because I can tell you that just my own personal opinion is I don't hear about them. If it wasn't for the fact that, like I said, I was going to VA, I wouldn't know about any of this kind of stuff. So, are we just taking the easy route and doing prescription, or are we taking a total team approach? And by team approach, I mean community team approach, to make people aware that these programs exist and that they're available to them.
Very good point, Jim. And Stacy.
I agree with everyone. I feel like we'll be a broken record by the time we're done with this. We say a lot of the same thing, awareness. As I was listening to everyone, I was thinking, Wyoming Medical Center does have like a chronic pain management program. And I actually don't know anything about the program and what its awareness is and what it actually does for patients and stuff. And so, definitely, like you said, bringing that awareness to what other programs and stuff do, other programs do, so then that way we're able to inspire and encourage other people. Chase, this is Jace.
Hi. Hi. So nice to meet you. What did you make? I need to interrupt. Sorry. Show us what you made.
That was like this.
It goes on like this.
All right.
Fantastic.
Oh man, sorry. Now I lost my train of thought. But anyways, so bringing awareness to the programs, you're okay, to those programs. And so that way we all know as providers what we should do to refer people and what they all encounter. So.
Yes. I'm hearing a lot of very common responses when it comes to MAT for sure. All right, so moving on to the chronic disease management, and again, reminding you all, the other folks on the call, if you have any other comments or you want to participate in this, you can just put that into chat as well. So now we're going to switch order with chronic disease management. So we'll start with Stacy, then to Jim, then to Sabina, and then last Joanne. So respond in that order, and we'll try and be that 1 to 2 minutes per response. We can hopefully get through, but I'm really enjoying these conversations, so I don't want to stop it.
Now, this is a topic I know much more about than pain management because I never really focused on that. But chronic disease, as the heart failure coordinator, is one of the leading causes of readmissions and death within the United States. And so what has been, methods available to help manage diabetes and blood pressure. So unfortunately, in Casper, our diabetes program is null to like almost nothing. We have a diabetes education program, but I don't feel like people refer to them as they will. As myself, I know I don't, so definitely getting that awareness out and trying to build up these programs that are important for people to really understand what they can do, because diabetes affects every aspect of the body and as a whole, and creates and causes so many other chronic disease problems throughout patients' lives.
Totally.
Just read me a question again. Like awareness again, like we always say, it's just making sure. And I was going to mention earlier with as resources, like money and funds to be able to pay for these programs too. You have to be able to pay for these programs so that way people can manage them and run them. And I feel like that really lacks in our community as well.
Great, thank you for that. Jim.
Okay, so I'm going to just piggyback off of what she just said and let you know that this is probably the biggest caseload that I have is chronic disease management, where people are dying prematurely out in their homes and what have you. And when I've taken a research into that and look at it and talk to families, I'll bet you the overwhelming cause that I find is that these people have been prescribed or put in a program that they can't afford. So, whether it's insulin or diabetic testing supplies or cardiac drugs or you name it, people either don't do it or quit doing it because they can't afford it. Now, if there's programs out there that address this, they're not really being told of that. They're just plain flat quitting. And ultimately, that's leading to their death. I guess I'm just going to go right on down here to the other piece of this, if I could. For providers, this is a great deal where telehealth and technology actually would be great. And I'll give you my own personal example. So like with the VA, I have diabetes, high blood pressure, and every day I do a telehealth via a little machine where I'll take my blood pressure, I'll take my blood sugar readings, and that automatically gets uploaded to my primary care provider, who then can monitor what's going on. And it's not a matter with this kind of stuff of seeing different providers or anything else. You know, we're using technology and saving the doctor's office visit, because the doctor's able to see and know if there's a particular issue and address it immediately.
I love those remote patient monitoring systems, because it also makes you accountable to doing that work as well, making you have to do that so your providers get that information.
Yep, I agree with that. How about Sabina? What has been your method of knowing what resources are available?
So my method of what resources are available, I don't really know. I live in Albany County. I don't know what's available, helping to manage all these, the chronic conditions. I haven't really looked around either, but my doctor also is not aware either. And so I think, again, education, awareness. I think Jim brought up a good point about medication and testing is oftentimes not affordable. And I think, again, looking at multidisciplinary teams involving clinical health educators, involving social workers. There's some great programs. I'm actually, through my work at Ivinson Hospital, where there's a chronic condition management program. There's Cheyenne Regional has a chronic condition management program with remote patient monitoring. We can't fill the spots oftentimes because awareness is not there. And then I think another thing that came to mind when people were talking is referrals to these programs need to be made much, much easier. I think when doctors have to fax a referral form, they're out, because they only have so much time in each visit. And so how can we make it very easy for doctors, and how can we create feedback loops for physicians too, that they know that their patients are taken care of? How can we engage pharmacists in helping with monitoring blood sugars? How can we train them to do some behavioral intervention so people can expand a little bit and have further reaching scope of work. And then getting back to lifestyle changes, you know, a lot of it can be managed, chronic condition management, lifestyle changes, physical activity, nutrition, stress management, and sleep. And how can we get that education out to our patients to prevent chronic conditions from happening? Starts much earlier than in old age.
That's a very good point, Sabina, is prevention, for
Can I
sure.
make a quick comment on this?
Mm-hmm.
So with this telehealth management stuff, it actually provides education as part of it. So when you sit down and get on your stuff, it's giving you sort of that lifestyle management tips, tricks, all that kind of stuff, asking if you're feeling a certain way every day, that kind of stuff is part of the program.
Yeah.
Yeah.
And there are funds across Wyoming to support these programs or implement them. The Wyoming Center on Aging is trying to partner. So if anybody is interested, contact us to start partnering with us so we can help and support our primary care providers all across Wyoming. And that's my different hat now. I just took my patient family advisory hat off.
That's okay. We want to hear all sides of the story, for sure. How about Joanne? What's been your method of knowing what resources are available?
Oh, we're so small. If it's going on, we know about it. The problem is it's not going on. And well, beginning July 1st, we acquired the clinic in our town. Otherwise, prior to that, it was owned by Rapid City, South Dakota, which I think you're in another state, certainly in another city, an hour and a half away. So we just didn't have that interest in in our clinic of reaching out for these resources. So I already wrote down the Wyoming Center on Aging to try to maybe get something going with them, because there's not much available. We did several years ago had a diabetic educator, a nurse practitioner that would come in, do a clinic 1 day a week with diabetes. And it was beneficial, but then she took another job and moved away, and there's not been anyone since. We've tried to talk, support one of our staff nurses to maybe go on and receive education to do this diabetes prevention and management. And we just don't have the interest, and we certainly don't have enough nurses to really say, okay, we'll pay you to go do this and we got your shifts covered, because there again, we've been busy just trying to take care of patients more so than we have in the past. So those have been struggles with that, just that there again, access. For us, it's access to a lot of things. I personally haven't had any experience accessing or problems accessing a provider, but I've been fortunate enough to not need to but once a year. So I can schedule that way in advance. And we do use telehealth, and mostly in our nursing home right now, we've used a lot of telehealth during COVID, not only for their primary care providers, but also for specialists that we would otherwise transport an hour and a half to their specialist appointments. Because of COVID, those specialists are getting on board with doing telehealth more. They wouldn't even consider it prior to that. So it has brought about more access for our residents with certainly less cost to our facility for transportation and more comfort for our residents. They don't have to get low, go onto a bus and make a long day of going to an appointment. So that's been helpful.
And I appreciate the chat that's going on right now too. Cindy had mentioned, can we have a Wyoming campaign for doctors and people to see how chronic care management can help with the funds? I think Deb had put in a resource in there, and she said we have several funding opportunities for chronic disease prevention with CDC. We call it 1815 funding, but Deb, do you want to say anything about that?
So Mountain Pacific is one of the contractors under 1815, along with the Wyoming Center on Aging. So we've done a lot of things collaboratively, where our funding has paid for some of the technology and the innovations. We do have an RPM, remote patient monitoring initiative that's going on right now. So I'm happy to talk to anybody who's interested in looking at creating or expanding programs in their areas.
Yes. And again, like this platform is meant to be a conduit. So just like how we're just resource sharing, and so you're seeing gaps in your communities, it may not be your next door neighbor, but we may know of something that's happening too. And so we definitely want to connect and get everybody squared away with that. So moving on, I think, Jim, you got to, and most of you kind of touched on this telehealth. And accessing providers. And I would say, I would totally 100% agree that access to care is a huge issue, not only for our disparate populations, but also our rural communities, and being able to have that option for telehealth, bringing in specialists that you wouldn't normally be able to have. And when we think about things like if our healthcare industry can get to the prevention of it instead of a knee-jerk reaction all the time. So let's see, I just got some. Okay, Sabina is sharing some stuff. I see Stacy said, I'm going to totally check this out. We provide a lot of supplies, scales, pulse ox, cookbooks for patients in need to be successful at home and prevent hospital readmissions. And that's another thing too, in terms of reducing cost and the financial burden is trying to keep people at home longer. So using that remote patient monitoring program really would help out with that. Any other discussions around chronic disease management?
I think what you just said is really the remote patient monitoring program gives the education along with the kind of behavior modification and accountability. And so I think that's a real win-win program or real win-win situation. Because you need both. Knowledge is power, but knowledge doesn't equal behavior.
Yep, I agree. Some of the things I captured just from your guys' comments is just one, knowing where resources are, whether it's for opioids or chronic disease management, affordability, and then to be able to refer to these types of programs. And, you know, given the fact that when we go to a doctor's office, when we do go in person, that generally it's like you get to be with a doctor for what, 3 to 5 minutes. So sometimes even those questions that we have, so being able to coordinate and communicate all of these types of resources sometimes can be an issue. You're having problems with your doctor's buy-in, Cindy? Are you able to come off mute?
Yeah, I didn't know if I could or if I can't.
Oh, sure. Yes, of course you can.
Yeah, I mean, we're doing really good with it, but I just feel like I'm constantly putting all my energy towards just trying to convince the doctors, hey, there's this patient and I think that they need remote patient monitoring, or, you know, have you thought about chronic care management for this patient? And I just feel like if I could spend my energy on just the patients and the doctors could just do that part and just, I wouldn't have to like constantly beg them for patients, it would be a lot more helpful. So I think just having some kind of campaign out there where they could see information, not just coming from me or the nurses, but from somewhere else stating, this is a good thing and this is why, or this is what we see. You know, I just feel like that's maybe would be helpful. I don't really know if it would be helpful. I would hope it would be, but I don't know what else to do to get their buy-in to just trust the programs.
What are their reservations right now? What are some reasons why they don't refer to you?
They're not, I mean, they're not really giving me any information. I think most of the time when I tell them I want this person to do it, they're like, okay, sure, yeah. But my problem is, can they just see it on their own? You know, like, because there's so many of them that, yes, like most of these 65 and older people with 2 chronic conditions need this. So I guess a way for doctors to see that it's not a waste of the patient's time or their time and just send them our way without us begging them to send the person our way.
Yeah. You might want to assess kind of like a current state where you look at, and this is maybe off what we're talking about, but just looking at what do they know about the program? And also, what are their reservations? These are the referrals we're getting from 20 doctors, and we're anticipating these many. And what are the barriers? What are the providers' barriers? That might be helpful for you to know. It might be a simple fix.
So yeah, just sending out an email, a mass email to the doctor saying, what are your barriers with this program?
Yep. And I agree. And I think I see Rita had mentioned in her experience, they had to find an educated physician champion and the rest will follow. And Deb kind of echoed that providers need to hear from patients who have success. And just in my experience as a nurse, the last 20 years of my career is peer pressure works for docs. You know, when it comes to just any type of procedure or workflow process or anything like that, it does. It helps to have that physician champion, because not all the time do providers want to hear from a non-physician. There's just a lot of merit in hearing from their colleague. So, and yes, I agree, share patient stories. So any other discussion on this? I love this. Keep it coming. I think that's a good segue to care coordination. So again, we'll start with Stacy again, and then to Joanne, then Sabina, and then to Jim. All right, so first question, what are the 3 biggest obstacles or challenges when someone is discharged from the hospital emergency department?
Let's see here, my 3 things, of course, cost. You know, insurance, a lot of patients, they need to have access to being able to pay for these, Jim talked about expensive medications and programs. You know, for heart failure, Entresto is probably like one of the #1 drugs that people can be prescribed to help them decrease death and decrease hospital admissions, but it also costs $650 out of pocket. And a lot of Medicare and a lot of other insurances don't necessarily cover it. So being able to afford those costs of those medications, that is helpful towards those chronic disease managements, as well as other like skilled services in general. So you have a patient who's in the hospital, not necessarily in the emergency department, but who needs to go to a nursing facility or other type of care facility because they're not safe to go home, but they don't have insurance, they don't have means to afford it. So then they end up staying in the hospital for a long period of time waiting to be approved for Medicaid and other funds to come through. Of course, education and perception, you know, making sure that patients in the community is educated on what they need to do and understand, and holding them accountable towards that. So with that, I think a lot of perception of our society right now is just give me a pill and that will fix everything, and not taking that personal accountability towards making some changes to be wanting to be, and what goes along with that is the education portion of it so that they understand. And that's my big part of my job, is educating patients on heart failure specifically. And I know we have a lot of other service line coordinators that focus on their areas. So that way they are successful at home. And then of course, communication among all aspects of healthcare, you know, between the emergency doctors, nurses, patients, family members. Communication is a key, and I want to just say every aspect of life. So those are my three, I feel like the three biggest obstacles that we experience, that I've experienced with that first question. And then I'll talk more about the rehospitalizations and what we do to focus on those here at Wyoming Medical Center.
Okay.
Everyone else.
All right, Jim.
Well, I think one of our biggest issues that kind of drives everything is the fact that we're a medically underserved state. And also, you have a good percentage of your population, when you talk about admission, readmission, emergency departments, that is their primary care, or at least they consider that to be their primary care. So, you know, I'll constantly be looking at histories where someone doesn't have a primary care physician, doesn't see a primary care physician, but has been in the emergency department, you know, 10 times in the last month for whatever. And so the hospitals are being used as a primary care, and that's not a good thing. And then being discharged from the hospital, basically with plans or prescriptions or whatever that, you know, comes down to the almighty dollar, can't be afforded by these people. And so ultimately they don't do it, and they end up back in there anyway. So, and I don't know how we address that.
Yeah, I would agree with that. I know that, you know, I've worked on reservations in North Dakota before, and I've worked with a few of the IHS hospitals in Montana. And I think it does come down to access to care and access to a provider and appointment availability. And so a lot of them, I am Native American, and I, you know, like just going to the emergency room because you're out of your blood pressure medication or whatever, and you can't get an appointment and they won't refill it without seeing a provider. So some of those little caveats that I think as a healthcare industry, I think we need to relook at some of those things and think twice about putting those types of policies in place and things like that. So, all right, Sabina.
Yeah, I 100% agree. Too many barriers for us as patients when it comes to primary care and access. But just looking from my own hospitalizations and ED visits that I've had over the years, is when I am discharged, I'm ready to go home. I don't want a discharge summary with 100,000 different things that I need to do and the medication that I need to get. I just want to go home because I've been in the hospital for a while, or I have been and I'm tired. I don't have the capacity to uptake any more information. So I would have liked to have just one sheet. These are the next appointments. These are the next steps. We're going to do them either by telehealth. You can come in. We can come to you in an ideal world and talk to you about the questions you may have post-discharge. So really just giving discharge information for 24 hours. And then the next day, I will have a visit with a care coordinator or with a social worker who can then explain all these things, the importance, explore my barriers, motivate me to get engaged. I think that would be really, and who can talk to me in a way that I understand and when I'm ready to receive the information that's important for my health. And then oftentimes I don't know who to call. You know, I don't want to go back in to the hospital and so I just don't call or don't make the contact, which again then leads to rehospitalization or another ED visit because I'm not taking care of myself.
Yeah, I agree that I'm right there with you. And it's just, you know, I think sometimes providers may forget that they're not there for wanting to sit there for the heck of it. It's that they maybe don't understand, or it's like, I don't know where to go from here. And now you got to track down 3 different pharmacies, like I'd mentioned before, because you prescribe me new medications and not one pharmacy has the same one. So now you got to go to 3 different ones. So yes, and Susan said that's an excellent idea, great firsthand observations. So Joanne.
I too had a lack of motivation to be compliant, and that kind of goes hand in hand with a lack of support systems post-discharge, whether they live alone or they live with a spouse who really doesn't comprehend their treatment plan or their medicines. Another thing we've noticed is many of them don't bring their pill bottles to the emergency room or hospital with them. And I've firsthand experienced where, you know, you just feel like this is not going to work. And I accompanied a discharge from the hospital to her house just to make sure her meds were fine. And man, she thought she had them all right, and she thought she had all her pills at home, but the doses were all off. Some of the meds had changed, and there was just that whole total disconnect with her that she didn't understand. So we've really worked hard at trying to do more teach back and even demonstrate to us that you know which pill is what and you understand what you're taking, and show us. Don't just say yes, 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 I understand. Take the time to have them demonstrate that they truly do understand and do that teach back. So that has been a big challenge for us. Not only with the patients directly, but even if they have a support system, the support system too is, yeah, we got it, let's go. So that's what we're working on.
Awesome. Yeah. Thank you, Holly, for joining us. I know some people have to kind of drop off here and there and join late and whatnot. So thank you for those who have been with us and need to drop off. So I think we kind of answered that challenges question, the second question here. So if you guys are okay, I think we'll skip to the third one, which is how can our healthcare systems be more collaborative with each other so they don't end up with unnecessary meds, tests, and labs. So we'll start with you, Joanne.
What we found is when you get on a EHR that maybe the tertiary care center, the closest to us where most of our patients go, if we share a system, we have one an hour and a half one direction and another tertiary an hour and a half the opposite direction, and half the patients go to one and half to the other. The one that we share an EHR with, we have access to so much better information. We really can provide better care because we can see what's been going on better. We can see current medications, and relying on patients many times for their history, they leave a lot of pieces out. So you know, when we started the EHRs and everybody had to get electronic, the whole point was so we could have more continuity of care. And now nobody can afford to do all the connections to all the different, there's just so much red tape to access records that if you haven't paid for that system.
I agree. Yeah. Yeah, we need to reduce all of that unnecessary red tape. How about Sabina? Did she step away maybe?
She's muted.
I just need to unmute myself. I'm here.
No worries. Okay.
So we're talking about how can health systems be more collaborative?
Yes.
I think pharmacists are completely underutilized profession in our primary care settings and our hospitalizations. You know, having a standard procedure in place or workflow where pharmacists review prescriptions regularly and check in with patients. And then also really go back to what matters to the patient and have a place where you can state that so that you start the conversation always with what matters to the patients. Because when you understand the patient's why and what's important to them, you create this really intense collaboration and have a lot more buy-in and patient engagement, I would say. And then utilizing and reviewing EHRs, assuming that they're working well and that there's not a lot of red tape, because that's very difficult.
Yeah, I agree with that. How about you, Jim?
Well, I find that this electronic portals and stuff where I can look up pretty much anything is the ultimate answer. But, you know, like some of the other people are saying, that cost and everything else, it may not be able to do that. And now we're in a system where, at least say in my county, you know, the primary care doesn't have access to the hospital where they might have before, and could go and check up on their patients and that kind of stuff. And the question to be asked is the person, the hospitalist or whoever, then following up with the primary care? And I can say the answer to that is no. So if we're going to fix it, it's got to go either where everybody can access electronically what's going on with their patient and get that information so they're not starting from scratch day after day, or your hospitals and other providers need to make a point of, if it's not their patient, calling that primary care provider and fill them in on what's going on.
Really good point about having that coordination and consistent communication with the patient's primary care so that there is that bottleneck. How about you, Stacy?
I agree with that completely. I know there's the Wi-Fi system that is trying to roll out through Wyoming. That's, you know, connecting those health systems together so that way patients aren't having repeat echoes or other tests. Knowing what patients, if they've been prescribed a medication and then it hasn't worked in the past, they don't go see another provider in 3 months saying, hey, why don't you take this medication? And then they realize that it's already been prescribed and it's not working for that patient. So kind of definitely understanding the continuity of care. And just like what Jim said with, you know, hospitalist doctors, which unfortunately right now with COVID, it's not the best time to talk with them, but, you know, creating that one way or that two-way road and connection between them, and not just having their discharge summary that is kind of pre-standardized form that they just kind of fill out and customize to the patient, for the patient, to make sure that they have the proper services that benefits them personally.
Yeah. And I definitely have seen that too, where it is just a standardized template. And I don't even know if some of the providers even look at that, because I've seen it where the patient comes back and they're like, this says I'm female and it's a guy. And, you know, I'm like, I am so sorry. Yep, that is not correct. So I will get you the new one.
That's my job, is I read physician notes, because I get a lot of my information from. And it's amazing what, you know, they copy and paste from day to day, and they'll say, oh, a patient will have AICD placed today, but it was placed 6 days ago, you know, and really making those standardized templates much more user friendly for providers.
Yeah.
When doctors on the outside or providers on the outside read those notes, they can kind of understand what the course of action in the hospital, and that has happened to a patient.
Exactly. And Susan just put in there, Stacy just touched on this, but is it your perception that these collaboration issues are being exacerbated by COVID and increased patient load? Do these issues predate the pandemic?
I think to an extent they predate the pandemic, but you know, I do believe doctors now don't have much time at all to really focus. I know the hospice group in general, they're probably short a couple doctors. And I know that a lot of the, like Dr. Dunn and some of the community doctors are helping, or the clinic doctors are helping with the COVID caseload, but you know, they're burnt out and they're tired and they're working hard. And so, you know, they're doing what they can do to just stay above the water, you know.
Yeah. Oh, I think we're all in that very full boat together with just being maxed out, and bandwidth is just maxed out with everybody, whether it's internet bandwidth because we're all online, or just mental capacity bandwidth. So that was a great segue to the next one, COVID-19 and infection control. And we do have this, but definitely if there's more comments or questions around COVID-19 infection control, please chat it in or just come off mute.
I want to say one thing that, not just with COVID in general, but I feel like the number of providers that are available aren't as great as maybe they were in the past. I could just be speaking out of this experience, but when it takes, you know, 4 or 5 months to get in to see a specialty doctor, that's not helpful to the patient. Or when I try to call for a post-discharge hospital follow-up appointment and the earliest they can get is in 3 weeks, you know, that's not beneficial to our patient population and making sure that they have adequate care transitions and follow-up care. So bring that awareness to, you know, nurse practitioners and PAs and doctors as well. They're all important to help care for those patients.
Yep, I totally agree. So since you are on the topic, Stacy, do you mind going first? When using the services of, or visiting or working in a long-term care setting, such as a nursing home, assisted living facility, what factors for preventing infection, such as COVID-19 and other illnesses, make you feel safe as a patient, family, friend, or staff member?
Oh, probably seeing that personal protective equipment and just awareness of it. I know in the hospital, because that's the setting I work in, they have a lot of mixed units where the COVID patients are mixed in with other patients. And so I could see that would be very stressful for family members to be walking down a hall and seeing all this equipment on the walls, in the doors, and then they have to go into the room next to that. So, you know, really reassuring those patients who are not in isolation that, you know, we're providing the best proper PPE so that we're protecting ourselves as well as you making sure that there's proper ventilation systems, making sure all that is in place so that way we don't end up giving these infections to other patients, not just with COVID, but with MRSA, VRE, those other resistant bacteria out there. And as someone who just recently tested positive for COVID, thankfully I was vaccinated and didn't have really any problems with it. You know, it's very concerning, you know, from a family perspective, what those people could be going through.
Yeah. Yeah. I totally agree. I think I'm sure every one of us has had in some sort, either had COVID or has had a direct contact that has had COVID, and just experiencing that whole, the unknowns and kind of the scariness of it, because, you know, even though, you know, as, you know, younger, even middle-aged people who don't really have any other chronic diseases, you know, it's a severe cold. It's just very stuffed up. But, you know, then there's other times where you hear somebody was a marathon runner and got it and passed away from it. So it's all of those unknowns, and it's very scary. So Jim, how about you?
Well, I just had my mother pass away from it, unfortunately. And I'm all too much aware in the work that I do with this. And I will say this, that your death rates that you see out there are underreported, not overreported. Just with what's going through coroner's facilities that aren't being tested. Now, as far as the safety thing, I guess for myself, herd immunity and vaccination and PPE is, I mean, that's it right there. What I would like to see is a campaign that educates people when you talk about PPE, that it's not about keeping yourself safe, it's keeping everybody else safe from you. Because unless you're wearing that N95, you know, you can still get it through there. And, you know, the trick is keeping you from coughing on everybody else. So, and you don't see that. You see it always in reverse. So, but I guess, yeah, PPE is probably the biggest deal there.
Yep. Echoing exactly what Stacy said. Perfect. How about you, Sabina?
Agree 100% with what Jim just said. I think education to everybody is important, and then role modeling the behavior. I think all of us, rather than being confrontive or just role modeling what we want our patients and visitors and everybody to do, and creating an environment among teams to hold each other accountable as well.
I agree with that. Keeping people accountable. You know, you can have your own personal beliefs and whatnot, but, you know, being accountable to those, like knowing that others don't feel that way. And, you know, it's just about personal safety, really, when it comes down to it. It doesn't matter if it's COVID or whatnot. If something is really bothering somebody, it's almost like, you know, if you purposely don't want to put a mask on around somebody that is very, very scared to get COVID, to me, in my mind, my personal experience, I feel like it's bullying, and that's not right. We don't encourage bullying.
And also teaching people the communication skills of how to approach somebody who might not wear PPE when it's appropriate, or to say it in a way that other people can receive it. My big thing, my background is in marriage and family counseling, is really, it comes down to communication, how I communicate. It's like, hey, you know, you're not wearing your mask is different than, you know, our policy here, or whatever, however you want to put that. A lot of people don't have the skills.
Mm-hmm.
And then because they're afraid to say something because they're afraid that it's going to be a confrontation. They say nothing.
Yeah. And I did read a study regarding vaccinations, and that's actually our next topic, but regarding, you know, what was the most effective way for people to understand, you know, the importance of vaccine. And it wasn't necessarily the safety of it. It was those personal experiences and that personal side of that story. Because when it comes down to it, we may be virtual, maybe hundreds of miles away from each other, but we're all, you know, we know that each one of us have a story and each one of us have a beating heart. So it's just something that we have to do for each other. So how about you, Joanne?
Well, I do work in a long-term care setting, and almost all of our residents are vaccinated. We have 2 that are not. If you asked our residents, they would say, I'm vaccinated, let my family in, I want to see their whole face. I haven't seen it in 18 months and I just want to see them. And that's been our biggest struggle. When the vaccine came out, they were all ready to get it. That was not an issue at all for our residents. It is more so for our staff. We have younger staff mostly, and those have been the challenge. The senior staff, those over 50 were more willing. We've struggled with getting the rest of the staff on board, and we'll continue to be challenged with that. I agree with what everyone said about the PPE. I think that makes people feel safe. I think when they walk into a nursing home, a clean and odor-free environment somehow makes you feel like it's a more sanitary environment and less apt to acquire a virus of any sort. So just those practices, we are regulated very heavily by CMS. We've had in our building 4 COVID infection control surveys. The state comes in and surveys frequently in long-term care settings to assure that everybody's doing the social distancing, the masking, and of course, just all the other infection control stuff that we always do.
I agree with that sterility smell when you walk in somewhere. You kind of feel like, well, they do care. So when you see that there aren't nicks in the walls and baseboards coming off the side of the walls and things like that, you're like, you know, that's the first and foremost thing that you see. You know, that's the face of the facility. So if they don't care about that, then they probably don't care about my health outcomes. That's a very good point. Any other discussions around this, COVID-19 and infection control? And you're more than welcome, if you think of something later on, again, just use that chat. So moving on to immunization. So we'll start with you again, Joanne, and then to Sabina, and then Jim, and then last to Stacy. And I believe this is our last topic. So starting with you, Joanne, what do you feel our healthcare system can do to help improve trust in the COVID-19 vaccine and the flu, as well as the pneumonia vaccine?
I feel the trust in the COVID is a much bigger challenge in our community. The flu vaccine, in our work environment, especially, you know, we've mandated for employees for a long time. Pneumonia vaccine too, I don't hear of much resistance. It could be it's just not accessible to people who don't have a primary care provider, and they're unaware of how important it can be for them. The trust in the COVID, that is a real big challenge. Now, Jill was just telling us that the memo just came out from CMS that there is a mandate for all long-term care facility staff to be vaccinated. It doesn't have a timeline on it yet, attached to it yet, but we're assuming that will come soon. But, well, I guess a federal mandate is a federal mandate, and I don't know that it makes trust. And what our big concern throughout our organization is that we're going to lose a lot of staff. We've found that the more time they have, when it first came out, we had a lot of resistance. And then, of course, with this new wave of COVID that we've been seeing in our community, they are seeing friends, families, and neighbors getting very, very sick and hospitalized, and some on ventilators. And when they're seeing people their same age, and seeing all the various ages that's touching any age group, they are starting to realize, you know what, the people that got the vaccine way back when, they're not sick, and the people who didn't get it are. So, giving them the opportunity to observe for themselves and make up their own minds seems to be more effective than, putting a mandate out.
Yeah, you're right in line. And I know I've been reading some, just national headlines, and that's spot on with like surveys that are done, is just allowing people that time to do their own due diligence and read about it and feel comfortable with it. How about you, Sabina?
There we go. So for me, I think 100% agree again. When people get pushed, they push back. Nobody likes that. And so allowing people to make up their own minds and make their choices, regardless of, what, I have to say it like this, regardless of others. You never win when you push people really hard and mandate things. Education is really important, I think, around this. Have read so much that I don't know anymore what is what. And I find that I'm medically pretty savvy, that I understand, but it's conflicting information everywhere and it's overwhelming. And then you give up and it's like, I'm just going to go back to my normal and just do nothing anymore. It pushes people into paralysis really around this. And so I think also just really realizing that, when you look at the pneumonia and what's the other vaccine you wanted, the flu vaccine, pneumonia vaccine, we know that there are different vaccines than the COVID vaccine, that it is differently administered as a different substance. So, and that's, I think, why we see better results with pneumonia and with the flu vaccine.
Yeah. And just to put another kind of question in there, do you guys feel that, just because your point there with the flu and the pneumonia vaccine, Sabina, so you feel like maybe in a year or two that there will be more trust within the COVID-19 vaccine?
So are you asking me? I'm telling you, I don't know. I personally, for me, no. I'm at the point where I am just really saddened by the fact that I don't trust anything anymore. And the more mandates come out, the higher my anxiety gets. And that's a real personal share that I'm doing right now. This has nothing to do with really professional information and my support for vaccination. It's just, I don't know. And I think I don't know if anybody else feels like that too.
Well, this is Joanne, and I think something we've talked about the last couple of days also is if they've had COVID and they already have the antibodies and they don't really need the vaccine. And so there's conflicting information out there and we really don't know the answer to that yet. And that really is a lot of our population as well that have already had it. And they feel that they're already immune and they don't need the vaccine.
And it seems like the goalposts are constantly changing, that nobody really has the answers yet. And yet they come forward and say, now this is the answer and this is how it is. And if you get vaccinated, this is going to happen. And then things change as we find out more. And I think this uncertainty that's produces a lot of anxiety for me personally. And I can imagine for other people as well.
Yep. Jim, how about you?
Well, the question being, how to improve the trust, I guess. When you take a look at flu and pneumonia and all those have been around how long? People won't take those either. So how do you improve the trust in any of this? Well, you have to have one shared message. And that shared message needs to come from a trustful source. Now, recent polls have said that doctors are among the highest group of people that people trust out there. And our doctors don't have a shared message. As an example, I just dealt with a COVID death where the guy had several more comorbidities, and one doctor is saying, yes, get the vaccine way back when, and the other one is saying no because you have this condition, you know, and, you know, so we don't even have consensus with the people that should be trusted to give us that information. And so if we're going to get the community to trust vaccines, we're going to have to get on board the people that they trust hearing from.
Trust is a huge thing, not just even vaccines. I would say just in care in general and just our health in general. It's a big thing to trust, because it's a lot of trust into somebody that you met, you know, a handful of times to tell you, yeah, this is good, do this. It's putting a lot out there. How about you, Stacy?
This is such a hot topic, you know, and, you know, everyone turns it into being such a political thing. I believe everyone has their opinion, and just like Sabine said, it's very difficult for them to change that opinion. But of course, education is key. And like what Jim said, making sure everyone's on the correct page, you know, and here at Wyoming Medical Center, Banner Wyoming Medical Center, they just enforced a vaccine mandate, and there's a lot of uproar among staff here not wanting to get it and having medical freedom to choose for their body and everything. So like I said, it's just definitely a sensitive topic, and trying to encourage people to get vaccinated for COVID, you know, let alone, Jim said, the flu and pneumonia. I ask all my patients if they haven't had a pneumonia vaccine, if they would like one. And I probably have 1 out of 10 who agree to get it, you know, and I don't typically sit there and try to give them a lot of education and change their mind, because I don't want to be forceful and try to push, I don't want to say my views on them, but trying to, you know, provide education to them so that way they make an informed, appropriate decision for them.
Yep, I think that's going back to, I can't remember who put that in there, being kind, and Stacy did, be kind no matter the political, personal opinions are. So yeah, I'm just echoing exactly what you just said. Stacy.
Yeah, I even said, you know, it's difficult I don't even want, and it's just this, I don't want to call myself a millennial because I kind of am, but I just don't even want to talk about it anymore, you know, and I know that's not the way to be either. You need to talk about this stuff so that way it can be fixed and improved, and that we can, you know, make things better for other future generations ahead of us, or yeah, in the future.
Yeah. And Sabina put in that good point. It's not just a medical issue, but it's divided families and communities, I would say, and friends, providers of care too. People are losing their jobs, their homes, and it just goes beyond than just a simple little teeny tiny spiked protein on that. You know, it's just how big of an issue and how much chaos it has caused our system and our world, really.
And so I want to say thank you to Stacy for bringing me back to what's important. That really was very impactful for me when you said be kind to each other and really think about what matters. And what matters is us getting along and not being divided. So.
Yeah, there's a lot to be said, even if it's through our computer screens right now, feeling connected and working together. We may have our own all personal stories and things like that, but when we come together, the end goal is that it is us as humanity that we are working together. So moving on to that next question here, what are some ideas for activating and engaging your community in educational and awareness opportunities to improve vaccination rates? So let's start with you, Joanne.
I'm sorry, had a little trouble getting the mute done. I guess consistent information. I think they're all getting information. We just need to maybe as a group of providers within our county communicate the same message and consistently communicate that message and educate them on really what's going on around us, because people take that more seriously when it's, you know, kind of your home and it's affecting you and people around you. So I think we would focus on that because there's so much out there. It almost makes people just not even want to listen to anything.
Yep, I agree. It's probably echoing what the others have said too about that vaccine. What Stacy just said, you're just exhausted. How about you, Sabina?
Yeah, I think getting back to just really keeping lines of communication open, encouraging people, educating them, and everybody needs to, all of us providers and healthcare workers need to be using the same language and giving a similar, if not same message. I think Crystal put in the chat that it's hard when a provider says you shouldn't get vaccinated. You know, how do you come back to that and contradict their trusted provider?
Exactly. Yep. Trust and trust is a huge deal. How about you, Jim?
Well, I think that community awareness and education is probably key, but having community awareness and education that's marketing the truth. And even if that campaign is dissuading people from getting the truth off social media, that's probably the biggest creator of misinformation and different information that there is. So, you know, our education program has to rely on one reliable source and then push that.
Yeah, being able to be reliable on that trusted source. It's a huge deal, especially I would say all of us coming from rural, small communities, and that we're just very skeptical of big government, right? How about you, Stacy?
Can I type in one more thing for you, Stacy?
Yeah.
Again, I've told you that the public has already voiced that they trust doctors, so why not get some of these doctors associations and stuff on board with being basically that public service announcement entity for us?
I agree with that. And I think social media has a huge role in this. We're so saturated with social media in our life that, you know, the way that the filters and the cookies and all that stuff is on people's Facebooks and other Instagrams and other types of social media, it already kind of pulls out what your views are and what your views and opinions are. And so you don't get to see the other side of things, if that makes any sense what I'm trying to say. You know, you have people post about vaccines and just say anti-vaxxers in general, not just with COVID vaccine, but with childhood vaccinations, you know, and how they cause autism. And in the minute you say that in your group, you know, they tend to, then that's all you tend to see. You don't ever get that opposite side. So, you know, bringing that awareness to. I do find in Casper here, and Jim and some other people in Casper might, there's the Casper versus COVID campaign that came out. And I think they've done a great job of providing like bright colors and education and billboards around town and really trying to bring that awareness to the town. Bring that awareness in so people understand and know what that real education and information is. That's all I have. Thank you.
Yeah, no, I think just some common things that I keep kind of hearing is a campaign and awareness and education, and I think just an opportunity and a platform for people to have exactly what we're doing right now, just these very honest and frank conversations. There's no activism, there's no shouting. It's just sharing thoughts and perspectives on all of this, and it's very, very beneficial for us. I do want to say I'm very, very sorry. We are over on time. We're 15 minutes over, unless I've lost track of time, unless I time traveled for some reason. We do have an evaluation link in there. Happy to stay on longer if any of you want to, but we can definitely take this leaving in action. I had a whole thing planned for us. We were going to do some figuring out some outcome measures and some goals for some of the key challenges that we found in this. So I think we'll pause that, and we're going to take this forward to the next Wyoming Quality Care. Quality Care. I just messed that up again. The next coalition meeting next Wednesday on the 15th, and that's at noon, and that link has been shared. So I see, oh, we don't have a separate one, so we'll send that out after this. But we do also have that questionnaire that we had put in the chat earlier. Love to hear your perspectives on any other things beyond these topics that we talked about today. So I'll just pause there and see if there's any other last minute feedback, questions. Any Mountain Pacific staff want to put any plugs in for anything? And Dow, I see I just put in there, there's providers in Wyoming telling patients not to get vaccinated, including your daughter. It's difficult to discuss the benefits after that. I completely agree. I know a lot of providers that have said that. And, you know, I think, I don't know if that's right or wrong. I think the right answer would be that you should do your research and list the objective risks and benefits. And I think that's what healthcare providers generally do anyways for any immunization. So I don't see why COVID should be any different, but that's just my 2 cents. Yes, thank you, everybody. I feel this was a very beneficial summit, and I hope that we do this again next year, and I hope that we can be in person. And just one more plug there, we have a regional call on Tuesday, October 26th at 3 p.m. Mountain Time, and you can register in advance. We can send that out too. So any of you who are interested in joining that, all are welcome. All right, again, thank you very, very much for joining today, and I hope you have a very wonderful rest of your day and safe drive home for those of you who are traveling.
Thank you to all of you. A lot of fun today.
Thank you, everyone.
Thank you. This has been great.
Yes. Thank you to our panelists. You guys did an amazing job.
Yes, amazing.
Bye.
See you later.